Ladies and gentlemen, welcome once again to another episode of the Think Clinical podcast. My name is Hamza. It's always good to be here. Thank you so much for all the support. Thank you for liking, subscribing, and sharing our video content all the time. We do appreciate all you do for us. And today's episode is going to be, and the subsequent episodes after this is going to be something very, very important that we have to be looking at, especially on the African continent. And this is a topic that really is dear to my heart because it talks about mostly leadership, and it's a series that I would like to go through. And this is just one of five of those that I would like to address as we look at this. So stick with me, especially if you're a leader or you're trying to build a healthcare business in Africa. It's important. I'm going to try to break it down and make it as practical as possible. Please remember to subscribe, like, and share. And if you haven't done so already, please remember to comment with your questions and any inquiries that you may need, and we will get back to you. So let's get right into it. So today's episode is going to be mostly around what the African healthcare CEO job looks like. What do they go through? What is different from other places? How do we reconcile the different environments, looking at what the African CEO goes through and what the one here in the developed countries will go through. So when we look at this into more details, the number that I want you to remember is 11. And that is the median number of doctors per 100,000 people across sub-Saharan Africa. Now the number here, and when we translate that to the United States, this number is 260 per 100,000 people across the US, or across the same population. But yet, when we look at this, and with the constraints that most of these African hospitals have, we have people performing open heart surgeries, we have neonatal intensive care unit services, we have complex oncology that is being done with 11 per 100,000 people, and a fraction of the infrastructure budget that most of these developed countries would have. So how does it work? How the question is, how do these hospitals really function? What role does the CEO play? What is different about the role of that CEO compared to the role of the CEO who is in a more developed country? The answer is not lack. It's more to do with leadership, and specifically a very particular type of leadership that I want to talk about today, because I believe it is one of the most underappreciated and also underestimated skill in the world. So remember to subscribe, like, and share. This is going to be one of the most exciting ones that I have to talk about. So let me paint the picture for you. On a normal Tuesday, as a CEO of a teaching hospital, let's say in Ghana, where I come from, okay, when you arrive at 7 a.m. to discover that the main generator failed overnight and the backup kicked in, and it's only rated for the ICU and let's say the operating theater. So you have all your wards that don't have any lights. The general wards have been on sporadic power for 6 hours. A nursing supervisor is at your door. 3 elective surgeries are scheduled for today. Your lead anesthesiologist is on leave, and the locum you hired cannot get in until noon because a road condition outside of maybe the road is damaged, or it's just they got stuck somewhere, which is very typical. It's also month end, and your biggest medical insurance payer, the one who owes you, let's say, 60% of your receivables, has just notified you of a payment delay. The pharmacy is requesting authorization for a supply run that exceeds your current petty cash, and your board chairman has called a meeting for 3 p.m. to discuss the capital expenditure proposal you submitted 6 weeks ago. This is just on a typical Tuesday. The question is, this picture I just painted for you may sound or look very dramatic, but I tell you this is the reality of some of the challenges that CEOs on the African continent or in a major institution in Africa will face just by walking in on a Tuesday morning. Now the research shows that, and this is the 2023 WHO African Region Report, which found that 56% of health facilities across sub-Saharan Africa experience power outages more than 4 times per month. More than 4 times per month. For hospitals, unplanned generator failures are among the top 5 operational disruptions cited by facility management. So this is a huge situation that these leadership teams have to navigate. And here is the leadership problem that nobody talks about enough. Most of the men and women who become CEOs of African hospitals are trained clinicians. And so when you look at some of the major hospitals, and again I'll use Ghana, some of the CEOs and most of the CEOs have trained physicians who have been who have never had any leadership experience, and they become CEOs. And we all know that skill set, yes, even though there are some transferable skills, some of those transferable skills are not really applicable in a context like this, right? So what are we saying here? What does the African healthcare leadership actually look like? What are the specific competencies that they separate the executives who transform these environments from the one who get consumed by them? Now, I have identified 5, and we are going to look at those 5 right now. Competency number 1, mastery of what we call adaptive resource allocation. So in a well-resourced healthcare environment, the skill is optimization because you already have the resources. The job is to deploy them efficiently. So you have the resources, you are deploying them efficiently. So that's the leadership skill here. In a resource-constrained environment like we have in most African environments and what most CEOs will face, the skill is adaptation. So your resources are incomplete, your resources are unreliable, and they are absent, and the job is to deliver outcomes anyway. So these are fundamentally different cognitive tasks that people have to accomplish. So the best healthcare CEOs I have studied and worked with share one habit. They maintain what I call tiered priority architecture. What does this mean? They have decided in advance, not in the moment of crisis, which functions as absolutely non-negotiable and which are important but deferrable and which are discretionary. So they've already made that decision ahead of time proactively, and that's what they are going to use. So the decisions are pre-made, and the crisis reveals the plan. It does not create the need for one. So the opportunity to react to problems doesn't exist because they've already planned and they know what should happen or which resources to deploy into what at what time, right? Now, the time to decide what is essential is before the crisis. In the middle of a crisis, you execute the decision you already made. If you have not already made it, you will make it badly. That is what you need to understand. Competency number 2, revenue cycle mastery and an informal economy. This is one of the most underappreciated challenges in African healthcare leadership. And I want to spend a moment here because it really has where all the dollar and cents consequences come in. So across much of Africa, healthcare insurance penetration is low. So when we look at a country like Ghana, the National Health Insurance Scheme covers just about 35% of the population on paper. But active membership with recent premium payment is significantly lower in Nigeria. It's significantly lower, but when we compare this to Nigeria, the National Health Authority covers less than 5%, which means that hospital CEOs have a large proportion of revenue coming out of pocket payments, which introduces significant collection risk, bad debt exposure, and cash flow. And have been in situations where we've seen people who they've had a medical care, maybe through a road traffic accident, with bills that because they do not have the health insurance, they cannot even pay for those. And effective healthcare CEOs understand that revenue cycle is not a back office finance function. It's a frontline leadership competency. They know their payer mix intimately. They have negotiated directly with insurance companies and been willing to walk away from deals that do not work. They have implemented point of service collection protocols that balance compassion with financial sustainability. They know that collecting 40% of a bill at the time of a charge is better than chasing 100% for 6 months. And competency number 3, people development as a survival strategy. And staff retention in African healthcare is not just an HR problem. It is an existential threat. So the brain drain from African healthcare workforce has been one of the most defining crises of for 30 years now. So Ghana alone has trained thousands of physicians, so we all know what those challenges look like. People actually get trained and they move out of the region because of one or two reasons. So they have to build internal promotion culture and negotiate salary structures whilst they cannot match Western wages. And this is some of the challenges that they have to go through at all times. And I have seen this play out in so many different ways. So it's important that we highlight some of these issues that they are facing and how we can get into this. And again, we have to be able to stay in a situation where a lot of the time people are able to appreciate, first of all, the environment they are in, the resources that is available, and the effort that the CEO is putting in to get this done. The competency number 4 is stakeholder navigation across formal and informal sectors. And if we look at the African healthcare sector and how it's set up, we have influences coming from two different directions. You have the formal sector where the Ghana Health Service or the Ministry of Health is regulating you, but you also have the informal sector where you have the chiefs and the people in the community where you serve also regulating you. And as a leader, you have to learn how to navigate these two. And that doesn't happen always. That doesn't happen at all in the Western regions, because the communities, yes, they do have a say, but the potential for a community, let's say, or a chief in Africa to be able to stall or delay a major hospital project just because the priorities or what you've laid to them is not aligned is one of the things that need to be looked at. And the competency number 5, psychological durability. This has nothing to do with an MBA, but one of the most important skills, because you have to be able to stay in a mindset that keeps you together for what the leadership model looks like. So this is the model we need. And I want to close with something very provocative. Of course, we spend a lot of time in global health talking about what Africa needs from the West. More funding, more technology, more partnerships, and some of that is true and important. But I think we spend far too little time talking about what the world can learn from African healthcare leadership. Because the competencies I just described, which is adaptive resource allocation, the informal economy, revenue management, the community stakeholder navigation, and the psychological durability, these are not deficits born out of poverty. These are elite skills forged under pressure. And when COVID hit in 2020 and hospital systems across Europe and North America were overwhelmed by supply chain failures and resource shortages, healthcare systems in several African countries responded with a level of adaptive speed that stunned global health observers. Rwanda stood up a national contact tracing program in days. Senegal developed an affordable testing protocol before many high-income countries had. And Ghana deployed community health workers through existing informal networks with an efficiency that took years to achieve in other countries. So when we look at this from a Lancet study that was published in 2021, analyzing COVID-19 health system responses, found that several low to middle income African countries outperformed wealthier nations on response speed and adaptive efficiency. So this is something that we know can be learned in the African continent. The question you ask is why? And the answer is because the leaders of those systems had been practicing adaptive leadership their entire careers. Resource constraints were not new. They had playbooks for operating without full resources because that was their everyday life and not a pandemic for them. The African healthcare CEO is not a diminished version of a global standard. They are a different species of leadership shaped by the uniquely demanding environment and to uniquely capture what we have here. So here's what I want you to take from this today. And if you're an aspiring healthcare executive in Africa, know your environment is not a liability. It's a training ground. The competencies you are building right now under pressure with limited resources inside healthcare stakeholder environments are globally valuable. Own them. And if you're a global healthcare investor, a development finance institution, or a healthcare organization looking to partner in Africa, I want you to stop leading with what you are bringing and start by understanding what already exists. The talent is here. The leadership is here. The question is whether you are humble enough to see it. And if you are at the diaspora physician or executive considering coming back home to Africa, we will talk specifically about you in episode 4. Do not miss it. This is the Think Clinical podcast, and thank you so much for your time. I appreciate you, and do have a wonderful, wonderful day.
White coat, black no top, playing like a